Hello and welcome. Today, we'll be discussing a rare and often challenging condition affecting vision, paraneoplastic optic neuropathy. This occurs when the body's immune system, in its fight against cancer, mistakenly attacks the optic nerve, the crucial pathway connecting the eye to the brain. Paraneoplastic optic neuropathy, or PON, is indirectly caused by cancer. While the tumor itself doesn't directly invade or compress the optic nerve, the immune system produces antibodies to fight the cancer cells. Unfortunately, these antibodies can sometimes cross-react with proteins in the optic nerve, triggering an autoimmune attack. This misdirected immune response is what leads to the optic nerve damage. The pathophysiology of PON involves a complex series of events. The underlying malignancy triggers the production of autoantibodies. These antibodies then bind to antigens present on the optic nerve, initiating an inflammatory cascade. This inflammation damages the myelin sheath, the protective covering of nerve fibers, and the nerve fibers themselves. This disruption in nerve function hinders the transmission of visual information from the eye to the brain, ultimately causing vision loss. Paraneoplastic optic neuropathy is a relatively rare condition. It's difficult to provide precise numbers as it is often underdiagnosed or misdiagnosed. It is thought to occur in less than 1% of cancer patients. It is more commonly associated with certain types of cancers, particularly small cell lung cancer, but it can occur with other cancers as well, including gynecological, hematological, and other solid tumors. The signs and symptoms of paraneoplastic optic neuropathy can vary in severity and progression. One of the most common symptoms is a gradual and painless loss of vision in one or both eyes. This can manifest as blurred vision, dimming of vision, or difficulty distinguishing colors. Other possible symptoms include visual field defects, such as blind spots, and decreased brightness perception. The speed of onset can vary from days to weeks. Diagnosing paraneoplastic optic neuropathy requires a thorough evaluation. This usually includes a comprehensive eye exam by an ophthalmologist or neuro-ophthalmologist, including visual acuity testing, visual field testing, and assessment of color vision. Neuroimaging, such as MRI of the brain and orbits, is essential to rule out other causes of optic nerve damage. Crucially, a search for an underlying malignancy is initiated, often involving blood tests for specific autoantibodies known to be associated with paraneoplastic syndromes, as well as imaging studies to screen for tumors. Lumbar puncture to analyze cerebrospinal fluid may also be performed. While there aren't distinct subtypes of paraneoplastic optic neuropathy in the traditional sense, the presentation can vary depending on the affected areas of the optic nerve and the severity of the immune response. Some patients may experience primarily optic nerve swelling, while others may have more prominent optic nerve atrophy. The specific type of cancer and the autoantibodies involved can also influence the clinical presentation. The treatment and management of paraneoplastic optic neuropathy are aimed at suppressing the immune system and treating the underlying cancer. Immunosuppressive therapies such as high-dose corticosteroids, intravenous immunoglobulins of VIG, and plasma exchange are often used to reduce the inflammatory response and prevent further damage to the optic nerve. Chemotherapy or radiation therapy is used to target and eliminate the underlying cancer. Early and aggressive treatment is crucial to improve the chances of visual recovery. Unfortunately, there's no specific way to prevent paraneoplastic optic neuropathy. However, early detection and treatment of cancer can potentially reduce the risk of developing paraneoplastic syndromes. Regular medical check-ups and awareness of potential symptoms are important for early diagnosis of both the cancer and the associated neurological complications. The prognosis of paraneoplastic optic neuropathy can be variable and often guarded. Visual recovery is possible with early and aggressive treatment, but many patients experience permanent vision loss. The extent of visual recovery depends on the severity of the initial damage and the response to treatment. Ongoing research is focused on identifying specific autoantibodies associated with PON and developing more targeted therapies to minimize immune-mediated damage and improve visual outcomes. Newer immunomodulatory agents are also being explored. Scientists are also working on ways to identify at-risk individuals before symptoms appear, hopefully leading to preventative strategies in the future.